Hi, my name is Carly Waters, and this is my Case Connections video presentation. Before I start, I just wanted to say that I was really trying to do my webcam and share my screen at the same time because I had done this great PowerPoint presentation, but I could not figure out how to do my webcam and share my screen at the same time. So you're going to see me hold up little note cards throughout the presentation, and that's just going to be extra information about the questions that were presented here. So sorry about that. I had this great picture of the urea cycle that you're not going to get to see either, but I sketched one out, so I'll do my best to explain it with that. So, all right, let's get started. So I chose case 1 and I chose case 3, so I'm going to start with case 1. So case 1 was discussing, a newborn girl appeared normal at birth, and then 24 hours after that, she developed lethargy, hypothermia, and apnea, or difficulty breathing. And so an attending physician wanted to order labs, and so the question here was, which diagnostic test would be the best determining factor to differentiate between the urea cycle and beta oxidation. So our couple tests that we had here were blood glucose, urinary acids, serum fatty acids, or plasma glutamine. So let's start off with blood glucose. So in the urea cycle and in beta oxidation, both of these cycles, usually there's hypoglycemia. So doing a blood glucose lab would not really help determine for us which cycle would be the best or would be going on. So I do not think that blood glucose would be the best option. So we can cross blood glucose off of our list. Okay. All right. So urinary acids is next. So both of these are also involved. Both of these pathways are involved in secreting urinary acids. They're not predominantly the pathways that are used. So by doing labs to detect urinary acids, this would not, again, be the best choice to determine between the urea cycle and beta oxidation. So we're crossing off urinary acids. Serum fatty acids, again, would not be the best choice as we're going down this list here. Beta oxidation does use fatty acids, but these are in the mitochondria and not in the blood, which is the reason that I did not think that serum fatty acids, which would be found in the blood, would be the best option. So we can cross off serum fatty acids. So now we're left with plasma glutamine, and I believe that this would be the best choice to differentiate between the urea cycle and beta oxidation. So the reason being is that glutamine frees the ammonium that's in the liver, and that goes into the mitochondria and is used in the urea cycle for urea synthesis. And so if there was a disorder in this, you would expect glutamine would be elevated. So you would be able to see that on lab work. And in beta oxidation, glutamine would not be elevated because it's not fully involved in this cycle. So again, if glutamine came back elevated, we would know that it was the urea cycle. And if it came back not elevated, normal, undetected, we would know that the cycle being used would be beta oxidation. So plasma glutamine is our answer to this question. Okay, all right, so continuing down. So the blood work that is discussed here says that blood ammonia levels are elevated initially, and then they rose even more twofold. So they were around 300, and then they rose to about 600. So they doubled. The uric acid levels are elevated, but the plasma citrulline levels were normal in the labs that were done in this child. So the question here is now asking what the deficient enzyme is, what the best deficient enzyme would be, and then what the least impaired enzyme would be in the patient where the uric acids are elevated. So I was thinking, so here I'm going to show you my sketch of the urea cycle. But So you can see here, so excuse my, my poor drawings, but if we look here, so we're in the mitochondria, and I'm going to be using abbreviations for the carbonyl phosphate synthetase 1, because I'm just going to say CPSI when I'm discussing it. So anyway, in the mitochondria, ATP and NAG and CPS1, they're synthesized into carbonyl phosphate, which we see right here. And so that's like the key point, I think, in this process. So when that is really elevated, when the carbonyl phosphate is very elevated, it can leak out of the mitochondria and it can go into pyrimidine synthesis. And then that can increase boric acid. So that would be the reason that uric acid would be elevated. So when we're talking about a deficient enzyme here, we would be looking for an enzyme that would cause a buildup in carbonyl phosphate, right? So our enzyme that would cause buildup, if it was deficient, would be this enzyme right here, the ornithine transcarbamylase, or the OTC. So I think that that is the deficient enzyme. I believe that the least impaired enzyme in this case would be the carbonyl phosphate synthetase 1, due to the fact that we need carbonyl phosphate. So that synthesizes carbonyl phosphate. So that to me would make sense to be the least impaired enzyme, considering we need this carbonyl phosphate. Okay. All right. And again, so clinically presenting, a deficiency in this enzyme, the OTC enzyme, correlate with the clinical presentation of this child with lethargy, hypothermia, apnea, difficulty breathing, and an increase in ammonia levels in the blood. All correlate with the deficiency in this enzyme. So that is why I chose that as my answer. Okay. So moving on to case 3. So case 3, we were talking a lot in the last section of the course, and we were talking about gout. So this 47-year-old man presents with severe pain to his great right toe. He's not able to bear weight on his foot, and there's no apparent trauma, which is also a sign of gout. He reports that the pain started last night, and it increased in severity, so kind of like a sudden onset, no trauma, showing you that there's some, possibility maybe of gout here. His physical exam findings were consistent with gout, and his blood samples were drawn and urinalysis was performed. So the question here is, what is the best explanation for the presentation of gout in this individual? And so it's either overproduction, decreased salvage of purines, or decreased urinary excretion of purines. So again, sorry for my note cards. I really did try and make the PowerPoint presentation work, but hopefully this is okay. Okay, so we're going to look first at overproduction in the amount of purines. And so in an overproduction in the amount of purines, so this would increase the amount of glucose 6-phosphate, and that would increase the amount of ribose 5-phosphate, which would increase the amount of purines that were present. So when this would be present, I would not expect for there to be a decrease in the amount of urinary purines that are present, like in this patient. So their serum uric acid increased, but their urinary uric acid decreased. So in this patient, if there was an overproduction in the amount of purines, I believe that there would be an increase in urinary purine output. So I do not think that this would be the correct answer. So I'm going to cross this off. Okay. So now the next option is decreased salvage of, in decreased salvage of purines. And I think that this is the best answer. So during decreased salvage of purines, it is converting, I have another sketch here as well. So So it's converting. So this is how normal purine salvage would work, right here. And when there's decrease in purine salvage, there is a deficiency in this enzyme right here. And so normally this hypoxine guanine phosphorybase transferase will work properly, and it will make these bases convert back into nucleotides. And so when there's a decrease in this, there's no conversion of the bases back into nucleotides. So these bases are still going to be there, and they're going to be increasing the uric acid, which will increase the amount of uric acid that is in the blood. Instead of having the uric acid being excreted out of the body in the urine, it will increase the amount of uric acid, which is what we saw in the lab work. So in this case, uric acid would be elevated. You would not have an increase in uric acid from the urine because it is being excreted in the blood, which is why I chose this answer as my correct answer. So I'm going to circle this as my correct answer. And the last one we have to discuss is decreased urinary excretion. So this is predominantly present in patients who are, this is probably the least common, and this is diagnosed in patients who are usually heavy alcohol drinkers or someone who has chronic kidney disease. And so this is because the body itself is either very dehydrated or it has a decrease in inability to actually make uric acid and secrete it from the body. So patients who have chronic kidney disease are going to already have a decreased urinary output, not just a decreased uric acid urinary output. These patients would also not have an elevated uric acid in the blood, which does not correlate with the lab work that is shown, which is why I did not pick this as my answer. So we can cross this one off. So we're left with decreased salvage of purines. So the final question here is talking about the potential impact of dietary modifications in gout. So this patient drinks lots of diet soda, and he recently started drinking lots of regular soda. However, both of these are high in fructose, and so fructose is bad. Fructose is going to increase the amount of uric acid that is present in the body. So here we have soda, bad. The best thing that this patient could do would be eating a low purine diet. So this would include things such as like bread, pasta, cheese, yogurt, vegetables, fruits, nothing high in purines such as soda and fructose in this example, or red meats usually, or seafood. Those things are all things that he should be staying away from. So this is the end of my last case presentation video. I hope you enjoyed it, and thank you for listening.